each of the panelists are going to do a couple of slides. I'll ask them some follow-up questions. We'll leave time for you all also to be able to ask questions, and they are going to self-introduce here. So Dr. Rebecca Bartels is up first, and she was in the state of Washington. So if you recall, almost 4 years ago, that was really where COVID hit hard first, with the first reported infections and a significant number of deaths. So an important story to tell. So I'm going to give you the clicker here.
Excellent.
And let you take it from here.
Thank you. Well, good afternoon, folks. I am Becca Bartels. I'm an infectious disease epidemiologist, and until recently, I was the executive director of infectious disease management and prevention for Providence and Swedish Health Systems on the West Coast, and actually oversaw the hospital in which the first COVID patient in the United States was hospitalized. As of October of this year, I have accepted a role as executive director of the Centers for Research, Practice, and Innovation with the Association for Professionals in Infection Control. I have that tattooed on my hand now so that I can remember.
Right, it's long.
I've been in the field for about 20 years and really appreciate the opportunity to talk to you guys about what happened during COVID and our HAIs. I have no idea which button.
The green one, right?
The
Yep.
giant green arrow.
There you go.
So how many folks have heard of James Reason's Swiss cheese model for human error? Most everybody, considering who we're talking to here. So I'm not going to give the details. I think most folks are pretty comfortable with that idea. But if we think about COVID and we think about the holes in the Swiss cheese, during that time, existing holes got larger, new holes emerged, and holes from the past opened up again. And our Swiss cheese became extremely holy.
Okay.
When we put those factors in which we saw these risk factors into different buckets, I think they can be lumped into three. With bucket one, higher acuity patients, and bucket two, shortages, really creating bucket three, crisis practices. Early in COVID, as we started to see our very high acuity COVID patients, we saw high acuity in patients that were non-COVID as well. And if folks recall, that was because folks were scared to go to the hospital. And so often would wait and delay medical treatment. And by the time they came to us, they were very sick. So having a much higher acuity overall in our hospitals, we had longer length of stay. We had patients with more lines, drains, and tubes, each of those being a point of potential infection. And our COVID patients often were treated with steroids, anti-inflammatories, reducing their immune status. Our COVID patients also were on prolonged ventilation, and we call these patients lovingly wet patients, often febrile, often diaphoretic, and often incontinent with loose stools. And as you can imagine, proning a COVID patient who is wet increases the risk of dressings being contaminated, makes it harder to bathe the patient, makes it harder to change linens on the patient, and makes it very hard to assess where your devices are inserted if the patient is upside down. As we're caring for these high acuity patients, we're experiencing shortages of all of the various types of healthcare workers. And our healthcare workers are working in a situation of high stress and fear. And I think the word trauma is safe to use here because following that working environment for such a long period of time, I think trauma is appropriate. Our nurse to patient ratios were significantly altered. We added lots of travelers. We used nurses that hadn't been practicing clinically for a long time. And we used physicians in settings and doing things that they had not done in a long time. For some, inserting lines maybe since medical school, and often providing ICU level care when that was not typically how they practiced. Atop of that, we saw all of these shortages, starting with PPE, but then rapidly moving into clinical products, so that our very stressed, understaffed nurses were then, and all of our healthcare workers were faced with attempting to utilize products that were different than the products that they have in their routine practices. So all of those things combined put us in a place where we changed our processes inadvertently, one small piece at a time. We reduced environmental cleaning, again, inadvertently, often because early on we didn't want more warm bodies in the patient rooms because of exposure, but then because of staffing, because we had so many call-outs and sick and exposed individuals. We had new patient placement locations because we were trying to generate negative air pressure. And patient hygiene was deprioritized, and I think this is the number one most important thing that impacted our HAI rates is we stopped bathing reliably, we stopped changing linens reliably, doing CHG treatment reliably over time. Our lines were inserted sooner because we were concerned about patients crashing, and they remained in later. We were more reluctant to take them out. We did lots of creative things to avoid going in the room, like having pumps with tubing that extended outside the door. And then often we didn't want to change the tubing because of our product shortages. We were worried we wouldn't be able to get more. And then nobody had time to do audits. And so all of our quality improvement strategies during this time suffered because there simply wasn't time to focus on those things. If each of these things had happened in a vacuum, or even 2, 3, 4 of these things at a time, I don't think we would have seen an impact to our HAI rates. But all of these small changes stacked together made a massive change. And it made a massive set of small changes to the individual processes we utilize to care for our patients. And you'll see this in multidisciplinary rounds and huddles and auditing. Many systems and hospitals have now picked that back up and are doing it reliably again, but at least 2 years went by where there were hospitals that were not doing those processes. Culturing, ordering, stewardship, we had gotten really far down the road on that, and we sort of lost ground with using, being shrewd about when we order cultures. Culture collection processes, much higher risk for contamination now than they were previously because of the training and the changes in staffing. And again, patient bathing and hygiene, absolutely critical in an area where I would suggest everybody take a look in their own organization. And then finally, device selection, where the device is placed and how long the device remains in place suffered during the pandemic.
So what policies, procedures, practices have emerged as a result of this, as you said, all these small changes that became this tsunami, really?
Yeah, I think the theme for 2023, and nod your heads if you agree or shake them if you don't, is back to basics. That we are finding ourselves in a place where thank you. We are having to retrain ourselves about what's important, what is fundamental care, and relearn these processes that we altered because we worked in crisis standards for so long.
Well, I think that's a nice segue for Shantae. So Shantae Walton is up next. So let everybody know who you are, and back to basics is the theme here, right?
Absolutely, it is. And thank you so much, Leapfrog Group, for allowing me the opportunity to share my perspective. I am eternally grateful. My name is Shantae Walton. I'm the Health System Director of Clinical Epidemiology and Infection Prevention at UCLA Health. And I am really excited to be able to share just what we've done over time and also just getting back to basics. But I think the first thing that we really need to consider, we do have a very important question on the table here is the spike over for HAIs? And I would like to say I'm very optimistic and think it could be if we return back to basics. Before we get into that, though, I want to take a brief moment just to really consider our healthcare workers, especially over the past 3 years and what they've gone through during the COVID-19 pandemic. And on a typical day, our healthcare workers are confronted with patient emotional traumas. And then when the pandemic happened, we saw it just completely overwhelm individuals. My role usually in the organization is to provide guidance and support for evidence-based practice and help influence those teams to adopt. But I spent quite countless hours really focused on supporting our teams to helping them feel comfortable with managing patients that had this virus. So American Hospital Association reported that a large number of employees experience stress, anxiety, frustration, exhaustion and burnout, and also overwhelm. And what was interesting in this study was that a fraction of those employees receive behavioral health support. So why is this important? I mention this because we want our healthcare professionals to come to work being their best selves in order to provide effective patient care. And if they're not able to do that, the likelihood of an error occurring is probable. And there are studies that exist that show emotional exhaustion is related to psychosocial aspects, which in turn had a significant impact on HAIs. So the take-home message here is invest in your healthcare team's well-being. You should have really robust systems in place where your teams can get the support that they need so that they can do their day-to-day jobs effectively. All right, so we mentioned, and I heard the hand clap, back to basics is what we all certainly need to get to. And I want to just kind of describe some, and I know I'm on a time limit here, that are really important. This is not an exhaustive list, but those that I feel are critically important. Collaboration, teamwork certainly is something that we need to work on, especially when we engage our patients, getting their voice heard as well when we're focusing on their care, and then also creating strategies so that we can support the teams, very important. And as Dr. Bartels mentioned, our healthcare bundles that are available, those evidence-based practices, we truly need to get back to what we know to be effective, and so that we can increase the reliability of the care delivery so that we can improve our outcomes. Every time there is an event, an HAI event, we need to be obsessed with failure. We need to evaluate each and every one of those events so that we understand the causal factors and those underlying challenges in performance, so that we can understand those trends and continue to create prioritized goals so that we can focus on reducing or mitigating that risk. In addition to that, leveraging IT solutions. I think many organizations have really started evaluating solutions that are available on the market, but best practice alerts are some of the things that we utilize in our healthcare systems that works, and also considering those practices that are critical to patient care, creating those hard stops so that we're forcing teams to really take a look and ensure that they're doing those practices. Supply chain management is one that we've discussed earlier, but we learned a valuable lesson during the pandemic. Standardization is typically what we shoot for in our organization, especially if you're moving towards high reliability. But we saw that when you have one product that you've educated on and then it's not available because of back order or whatever the issue may be, we really need to consider, are there maybe a few products that we can have our teams well-versed on, so if we have to deviate or have to make that switch, if they can do so quite effectively. And also if you look back over time, 2019, I studied the FDA website. Since 2019, we've seen an increase in the number of recalls, both involuntary and voluntary, related to our products and medical devices. We need to consider how that impacts patients. Over time, I know that our FDA teams are looking into this, but I think creating a system within organizations so that you're routinely monitoring when these events happen and you can quickly recall those from your areas will be very, very important.
So one of the things that we talked about on the prep call that hasn't come up yet, Shantae, is some of the contamination challenges on products that are used on patients. And I was kind of overwhelmed by how many different types of products and services and machines and what have you as you went through that. Can you talk about that a bit more? And I think that's also a critical point for getting the rates down, even further. Obviously, as I said, they're headed in the right direction, but this sounds like a big issue.
Yes, absolutely. So just to give a little bit of context, I've seen just year to date approximately 60 or so recalls for medical devices and products. About 20% of those were related to sterility challenges or bacterial or fungal contamination. Now, these are products that routinely are already used on patients by the time we receive that recall notice. And so really important, that's why I mentioned we really need to focus on getting ahead of the game versus being very reactionary. I know the FDA earlier in the year requested about $7.1 billion, and part of that funding was going to be focused on strengthening the system for safety of products and medical devices. And so I'm hoping that continues, that plan continues. But on top of that, FDA and also APIC, Association for Professionals in Infection Control, which is tattooed here on her, there's a partnership, or there was a partnership where there are focus groups so that infection prevention professionals can provide that guidance to FDA so that they know what, at the front line, what the challenges are so that they can start to make progress. So I'm hoping that also will help, as well as all of you, if there are things that we can do to continue for that accountability.
All right, thank you. All right, so next up is Dr. Stephanie Taylor, and she has a completely different topic to talk about that for some folks might be new, and sounds like it has a huge impact on these infection rates. So if you could fill everybody in on who you are first, though.
Okay, so hi everybody, I'm Stephanie Taylor. I've been a physician for a long time, evidenced by gray hair. Done three training in 3 specialties, mostly pediatric oncology is my primary clinical work. And then somewhere around 2005, I began to think about the sort of cohort of infections in different parts of the hospital where I was working in. I began to think the building had a role in this. Being a physician, my colleagues didn't really know much about building systems. I didn't know much about buildings. Facility managers saw me coming and they would run the other way. So I went back to school, got my master's in architecture, and designed hospitals for about 7 years, so I could really understand the healthcare environment because I was so concerned about HAIs. So as I came back from architecture school and designing hospitals and looking at what the infection preventionists were doing to assay whether or not a space was considered clean or not, there were sort of these surrogate metrics, ATPase wipes, settle plates, et cetera. And it occurred to me that the patient is really your most sensitive and your most relevant metric. So why don't we use patient outcomes as a reflection of proper building management? So with that in mind, I'm also fascinated by the whole concept of the microbiome of our bodies that we now know a lot more about thanks to metagenomics. And how does the building influence the microbiome of the building, which then has implications for our microbiome? So around this time, 2013, I found out about a group of microbiologists who were they wanted to track the movement of microbes through a brand new hospital building for over more than a year, starting from before there were patients or staff in that building. So they said, we're going to monitor environmental parameters, all the things you see listed there, in patient rooms and in the nursing areas, and then we're going to use our metagenomic analysis tools to track microbes to see how they change, how human occupancy affects microbes. And I thought, well, that's cool, but what about patient outcomes? So if they're collecting all this data on the patient room environment and on the movement of organisms, whether they are commensal or pathogenic, why don't we look at patient outcomes? So how many people are really happy to give away infection control data? And there were about 400 patients who'd been in these spaces. And he was from England. He said, that's an awesome idea. Next thing I know, there are 400 complete medical records in my Gmail account. I was like, wow, this is my lucky day. He got fired. He's now out in California. And I dug into the data. I thought I had died and gone to heaven. Meanwhile, the hospital lawyers started sending me letters saying, don't look at the data. And I was like,
Whoops, too late.
Way too late. But it scared me, I'll tell you that. So this is, you can tell I'm not an architect. I don't draw like an architect. That's a patient room, the box. So you see all the metrics that we were monitoring every 5 to 30 minutes in a brand new hospital. And then we were taking a massive amount of environmental data. It also included things like hand hygiene, compliance, and visitation, all the stuff you see. And we had a statistician who correlated patient outcomes with these data points. So just think to yourself, what do you think was the most relevant here? Just think about it. You don't have to speak up. So we sent the data off, and it came back telling us, the statistician came back, the first statistician said, the most powerful driver of HAIs, or I won't say driver at this point, the most powerful correlation was low relative humidity in the patient rooms. And I was like, this guy's smoking something. So we fired that statistician, hired another one, and said, tell us what we think tell us what we expect to see. And that second statistician came back saying, when the relative humidity was less than 40% in the patient rooms, the HAI rate was high. And you can see here it crosses viral infections, bacterial infections, it crosses respiratory, GI, urinary tract infections, which is the green dotted line, was more correlated with mobility and hygiene of the patient. But cellulitis, conjunctivitis, these things were very much related to relative humidity. So I was perplexed. I did a very deep dive into the role of water vapor in our health. Low relative humidity dries out our respiratory immunity. It creates more airborne microbes, and the microbes that survive in the air happen to be the most pathogenic ones. Antibiotic resistance is transmitted horizontally without even touching a patient through the air. So I began to realize that a moderate amount of water vapor in our environment is key. We get the flu in the winter in New England because the indoor air is dry. Bring in outdoor air, you heat it up, the relative humidity plummets, and it's terrible for our health. So now when I think about this sort of balance between the infectivity of organisms and the robustness of the human immune system, they're both important, but how is our environment affecting our metabolism, our immunity? We all know people who go to the same party and one person gets COVID-19 and the other one doesn't. Why is that? There are other factors involved. But the piece I think we're really missing in hospitals, in commercial office buildings, in schools, in our homes, is how does air affect our health? And I'm not just talking about engineering thresholds of particles or CO2. I'm talking about a deep dive analysis of how these factors independently and in combination affect our health. So this was before COVID.
No, you're good.
Oh,
Good.
so this was before COVID. So after outbreaks began to happen around the world, a couple of folks at MIT and I were wondering why was this one latitude around the Earth where the first outbreaks were? So we did about a year and a half analysis to answer that question. So we poured all of these variables into our statistical analysis. So government shutdowns, all these public policy mandates, human demographics, so comorbidities, age, et cetera, and then environmental parameters, both indoors and the ones we could get, both outdoors and indoors, so things like precipitation, particles, UV exposure. Came back that low indoor relative humidity was the most powerful driver of new cases and new deaths. And we identified once again this relative humidity range indoors, 40 to 60%, where our health is the most protected and airborne pathogens are low, and the pathogenicity of particles in the air is diminished. So if you think about the hospital and you think about device contamination, your surfaces, things are resuspended and then resettle. So how do air factors in the air influence things you might not have touched? I mean, the implications are huge. So why don't we put that into a real world situation? So now I'm the CEO of a company called Building for Health, where we actually have a indoor health index based on ongoing monitoring, indoors and outdoors. So this is a study that was done in Indiana, at Methodist Hospital, looking at 14 operating rooms. So we were monitoring them, and if your room met certain requirements, both individual and combined thresholds of indoor air constituents, it would be in the green. So green was optimal, yellow was not so great, red not great at all. These were managed according to ASHRAE and ASHE and FGI, room air changes, et cetera. So at the end of this study, when only the green rooms were used for surgical procedures, and there were different types, some were open, some were endoscopic, but when only the green rooms were used, at the end of this study, there was an 87% reduction in SSIs. And presumably, there's always that Hawthorne effect were people behaving differently in those rooms. I believe those were well controlled for. So by managing the environment by itself, there was a huge improvement in patient outcomes. And the other thing in this day and age with climate change and net zero energy requirements for buildings and decreased carbon consumption, we also were able to turn down the room air changes in those operating rooms by 5 air changes per hour and had a cleaner environment because you had less particle resuspension. So those hospitals saved money both from the management of the building point of view in terms of energy and all that goes along with HAIs. So it's really exciting. And I was just thinking about it. One more minute?
Sure.
I live in northern Vermont. I live in Stowe. It's beautiful. Come visit me. We have a pond, and I was thinking about how we tend to ignore the air. But I thought, okay, if all of a sudden fish started turning belly up in my pond, I would say, okay, darn, what's in the water? I'd do some water testing on an ongoing basis. And that would be my first step. And yet when it comes to human beings in an airborne environment, we don't do that. The air is scary. It's hard to control. It crosses country lines. We can't blame somebody necessarily for what's going on in the air. We love to blame people. And yet it's so incredibly important. So I believe that, and I spoke at the IHI a couple years ago, I believe that managing the airborne environment from the perspective of human health is probably one of the most important things that we do not do. So that's the end of my...
Fascinating, absolutely. Stephanie, I was thinking about how in the early days of the pandemic, the hospitals were using all kinds of rooms to take care of folks, sort of non-traditional spaces that may or may not have had the same indoor air management, right, as a legit patient room or an OR. So have you thought about, the impact of that in early pandemic days and how that might have played out?
I think the pandemic definitely made people aware of airborne exposures. We still didn't think about the influence on our immune system. So when HAIs went up during, that graph that you showed in the beginning, I think that was multifactorial. What was the virus doing to our immune system? I can't say that it was air pollution because air pollution diminished. But
That's true.
One of the best things from the pandemic, I think, and one of the best things about mask wearing is you humidified the air that you inhaled.
Yeah.
So you were not desiccating your respiratory epithelium. When your respiratory epithelium dries out, you don't produce interferon. There's like a mechanical sensor change in your cells that are supposed to produce interferon to protect you that doesn't happen in a timely fashion. So I think mask wearing is good because it also conditions the air we breathe as well as prevents some exposure. But that hospital with the study, so what do you think they're doing with it? What do you think they did with their patient room humidity after that? They didn't do anything.
No.
Because the engineers said, well, patients want windows, and if we humidify, it might cause frost or condensation on the windows. So it wasn't addressed.
Okay.
You know, engineers hate the word humidity because it bring them in on a Saturday for liquid condensation, which you don't want. But anyway, mask wearing definitely humidifies the air you breathe.
All right, thank you. All right, last but certainly not least, Dr. Lee Fleischer has been so patient way on the end there. If you could tell everybody who you are and what you do, and also some really interesting perspective to share.
Yeah, thanks so much. It's very hard to follow all of them, and some of the themes are very similar. I am a professor emeritus of anesthesiology at the University of Pennsylvania. Probably most relevant, I was the chair of anesthesiology when COVID hit, but in July 2020, I became the chief medical officer and the director of the Center for Clinical Standards and Quality at CMS, and therefore my job description was responsible for the quality and safety of 165 million Americans, which I like to think I took seriously until in July 31st of this past year, my wife said it's time to come home and return to Philadelphia. So I'm going to go, what I'm really proud about, at the beginning of the pandemic, I was overseeing the nursing home facilities in this country, the 15,000 plus, as well as the hospitals. And I still remember getting daily calls from the administrator to say, why aren't things getting better? And one of the things that we saw, and we sent out teams, and in fact I went out in one locally in Philadelphia, was it really was about implementation, particularly in the nursing home facilities, which is different. It's a little better when you have all these infectious disease experts in the hospitals, and particularly when you have others telling you you're wearing your mask wrong. But talk about architecture, Jack and Jill bathrooms. We watched, and I got told stories about how the staff would go in thinking they were doing the right thing. They were still our healthcare heroes, and literally taking off their PPE in the bathroom, coming back through the residence room and getting reinfected. Mm-hmm. And they really didn't understand. And how many times, let me ask, how many people in this room through the pandemic were frontline providers? So a small cadre. I was too. I continued to practice anesthesia while I had this job. And I watched, even at my major academic medical center, people had the masks down here, were cockeyed. They weren't wearing their masks right. So we were very proud, working with the CDC and our colleagues and Michelle Schreiber, to put out the call to arms, so to speak, in the New England Journal. I chose to put it out in a major academic piece. I still remember the discussions to really sound the alarm that things had gotten worse. Not unexpected. It was based upon using the quality measures, the same measures that Leapfrog used, and I was so pleased to see the changes. But one of the questions was, how do we build a resilient system? It's not just about the checklist. I will tell you, I'm very proud to have worked and have given a faculty appointment to someone named Chuck Bosk, who wrote the book Forgive and Remember. And when he looked at the Michigan work around HAIs and the checklist, he reinterpreted it. It wasn't just a checklist, but the checklist within the social context of a movement, which I know is so much part of Leapfrog, a movement to say, this is important. And that to me, and I actually have spent, I'm going from engineers to social scientists, spent a lot of time thinking about, and that's what we were trying to call to arms there. Now, what became interesting, and let me see if I can do this, give an homage to a very dear friend of mine, Sigal Barced, who passed away. She was an organizational psychologist at the University of Pennsylvania. She passed away from a glioblastoma. It's very public, so no HIPAA violations. But I woke up one morning and Sigal had emailed me and said, I just wrote this piece. You got to tell me what you think, which is the contagion we can control. That her fear was that fear itself would change the way a lot of the things you described. So my poor department, we did a study, and we actually queried, and remember, this is about April 2020. So this is about a time when there's not enough PPE, there's fear that if you bring it home, I was having faculty, I went in every day to support my faculty, residents, CRNAs, but I was having faculty and others who were actually sleeping in their basement, who had asked for hotel rooms when they were in the ICU because it wasn't their own mortality that they feared, it was bringing it to their family. And we asked the question, what caused all that, and what caused the issue of burnout that you talked about, and what could we do about it? And you see here some of the factors we found. It's very scientific, but if you basically at baseline have a certain amount of anxiety, that influences the amount you're going to have in the moment. And what was really interesting is the direction of the arrow. The anxiety caused the burnout. It was living in a state of continuous anxiety, not just intermittent, that really changed things. And if you actually had a situation where our leaders didn't try to control that emotional contagion, things were getting worse. And I'll talk a little bit about psychological safety next. But that, to me, became a very important point. So as I started to look forward and from my policy role, and now that I've returned and continue to practice clinically, I remember what it felt like in those front lines, and you talked about it. In fact, when we went and tried to decide for those nursing home residents who decided to get the vaccine before the mandate, people said we should call them healthcare heroes. And I called Sigal, and she said, "Are you crazy? Anybody who goes and takes care of a nursing home resident is a hero." These are community champions because they're really protecting the entire community by getting a vaccine themselves. And using and understanding the levers of language, using the levers of organizational psychology, using the movement, I think is really important. But recognizing what the burden, and you talked about, on the system. In fact, one of the things when I practice, many of the people I practice with, particularly the nursing staff, actually grew up during the pandemic. They had their clinical skills, so to speak, by saying growing up. And in the old days, if I needed something, they would, and pre-pandemic, I had worked with this team so much that they would literally hand it to me when I was in trouble. They would be paying attention to what I cared about. But at the beginning of the pandemic, getting very personal, we told all the nurses, stay away from the head of the bed, because that's the most dangerous part. Stay away from the aerosolized procedures, which intubation by an anesthesiologist is, putting the breathing tube in. So now, the idea of what we taught, I would add on to the getting back to basics, is the basics need to change because we now have an unstable staffing situation. We don't know who we're working with. It's not like the airlines, because if I have a nurse that day, and they happen to be the ones traveling the most, they could have spent, I'm at Penn, they could have been at Temple, they could have been at Einstein, they could have been at Abington. And each facility is different. And we have to figure out how to implement and adapt to the local facility, given the resources, given the fact that we haven't standardized all our equipment. And we don't standardize, unfortunately, where everything is. So the way I've been thinking a lot about this is given these unstable teams, and I give a great homage, that's Amy Edmondson, for any of you, The Right Kind of Failure. You talked about failure. She just published a great book. For those who are wondering why she spends so much time in healthcare, besides she picked that, her husband is actually the dean of Harvard Medical School, a little known fact. Nice power couple. But she's studied a lot about were people willing to fail and fail differently in the right way? And this is really the thing that I've spent a lot of time having trained about 1,000 residents in my career, also being rather senior, that the residents are fearful, I will be honest, of learning from mistakes. That idea of how do you get high accountability, and really the idea that she has, and I really like how she anchors, that if you have high accountability and you have low and high safety, that's learning. And reframing that if you make a mistake, which people do, as long as you learn from it, we'll get to the right place. So I think as we move forward, and I would urge, and I think, Leah, congratulations on all the awards and the accolades, and I think you do this as part of the movement. You know, the one thing I brought to the Quality Conference in 2022, I brought Angela Duckworth. How many know GRIT? And she talks to the 3 Ps, purpose, practice, I forgot what the third one is. But then she talks about hope. Well, clinicians have a purpose. They actually do want to do the right thing for people. There is no question in my mind. There may be a few who are not, but overall, that is their goal. And hopefully, they're all doing a lot of practicing, and they're understanding how to deliver that care. But they've kind of lost hope. And one of the things that I'm very proud of, we were just talking with Missy about this, is one of the things Michelle Schreiber and I are very concerned about is if you go to a board meeting of a hospital, and I've sat in enough of them, finance takes 90%, and you might get a mention of quality assurance and performance improvement. So in 2023, in March, CMS put out a requirement that every board has to actually put as part of the board meeting a discussion of their quality assurance and performance improvement with looking at data. And the Joint Commission and Jonathan Perlin has said, we like this, we now have this guidance from CMS, and that they're going to look at the board minute meetings. And the way you're going to show it is you didn't spend 2 minutes on it. You didn't relegate it to a subdivision of the board where nobody at the board talks about it, but it really is the leadership that does. So I'm hoping that sort of what Michelle and I and others started within CMS, that we can use those levers, which I think are really the important things. So a lot of us have talked about, I would call them levers, to ensure that the system goes in the direction we want, which is the best care for patients.
So I know that the focus is on the HAIs and, keeping those rates down and going down even further. But Lee, what you were saying about the unstable teams, and you have, resilience was in the title of that article that you showed on your first slide. If we could pivot to patient experience, because I know obviously the unstable teams and the resilience factor had a direct relationship to what was going on in the patient room and the infection rates. But can we talk about patient experience? At the beginning of the panel, I mentioned that, the measures have declined in terms of outcomes there. So your thoughts on the resilience factor, the instability, you have psychological safety, performance pressure, all these things that are impinging on the providers.
It's an interesting question, and I think I had published with the team there. There's a couple things I think that is going on right now. Part of it is I am worried about who's going to be taking care of me as I get older, how they believe the true north is, how they have learned or not learned during these 3 years, how to talk to patients, what the patients need. So that's a big component, but I will also tell you that it's a different experience taking care of patients, because you have to, our country's unfortunately very polarized. And I can say I was the one who mandated vaccines for healthcare, and in some rooms I'll get cheered, and in some rooms they'll attack me. And in fact, one of the things we put out is, and I think you alluded to this, is we need to protect our healthcare workers, because there's actually a tax on healthcare workers that are coming at facilities. So how do we think about telling them what patients require more, and at the same time making sure not only that they're psychologically safe, but that I think this is a time for leadership of health systems to stop talking about the money and focusing on what's important.
You know, I don't know why, living in Florida, it didn't occur to me the polarization of, you know, the population having an impact. But, you know, that's a tough one right now to factor in with everything else that healthcare workers have to deal with. So we have about 10 minutes. And what I was thinking was, if we kind of go down the line and, you know, kind of final question before we turn it over to the audience, knowing what we know now type of question, what would be a recommendation you'd give to hospitals, not only to keep the HAI rates down, but, you know, to have them go down further in times of increased stress? Because again, you know, you hate to think about having another pandemic level stress happen, but I've heard enough people say it's not if, that it's when. So what would be, Rebecca, have you go first, what would be a recommendation?
I was hoping
One.
to go in reverse order.
Oh, you want to go in reverse order? Well, Lee can go. You
I'll
wanna
use a
be the big
lever.
finish?
Let's do that.
Okay.
Okay, he's going to go first. You'll be the big finish then.
Yeah, I truly believe that CMS has a huge lever, and I tried to exert it, which is the plans for emergencies need to be real. They need to be practiced. They need to not be bought from one of the consulting firms,
Okay.
but actually locally developed, that people know how to do it, and that the next time this happens, we just flick the switch. Because that Washington State First Nursing Home,
Yeah.
nobody was there. And they were part of a big chain. And once the nursing home director got sick, nobody knew the plan.
Okay. Right, Stephanie.
Are we going this way?
We are.
So I would say to broaden our lens, to understand the impact of the environment on our bodies and on microbial pathogenicity, and really get away, and really, I guess, just embrace the air as a hugely important factor, both for human defenses and microbial pathogenicity. And it's not us against the microbes, you know, that we've sort of moved more in that direction since COVID-19. But when we implement things like, you know, air cleaning devices and et cetera, you know, be aware of unintended consequences. I'll leave it at that.
All right, Shante.
I would say pay attention to your data. Lots of times we create action plans and we don't necessarily consider what the data is telling you. So listen to the story of the data and allow that to guide you as you continue down this road.
Yeah. All right,
I
Rebecca.
wish I had something more genius to say now that I decided to go last.
I'm sure you
but,
will.
I feel like building redundancy into staffing is really important. And, you know, certainly we're not going to be able to continue on the path that we are now with staffing over the long term. And we're going to have to begin to outsource some of those things like documentation, et cetera, to folks with a lower level of skill. And I think that it makes a lot of sense for us to figure out what those things are now and to really work towards those models where we can support our nurses in doing clinical care and take away a lot of the other type of work, so that if we find ourselves in a situation like this again, that we'll be able to more readily and nimbly activate those other resources.
Okay, great. Well, see if we have any questions in the last few minutes. All right, looks like we have right up front. I don't know if you have, oh, the microphone is coming.
Hi, Michael Richardson, St. Bernard Hospital. Great presentations, by the way. So I was wondering, do you believe there was a cultural shift, and I use this term cautiously, towards self-preservation and away from patient safety? And if so, do you think that's reversing when we talk about patient experience? Of staff not wanting to go into patient
He's
rooms?
coming out of his seat.
I knew Lee would get this one.
You know, it's not self-preservation. It's preservation of the health system. We went through the most unexpected national crisis in this country, and our health system, I would actually reverse what we say. Our health system survived. It better learn from it, and it didn't come back fast enough. But I actually think, and thank you, Shantae, I think the health system did an amazing job, and that's why I was willing to go into CMS, because I think some of the flexibilities that were allowed before I got there were allowed the country to be taken care of, my perspective.
You know, I would say early in the pandemic, I think we saw some of that folks were so scared. And I think, Lee, you described, you know, wanting to sleep outside the home or in the basement, et cetera. And there was a shift where a lot of people left healthcare at that point. And I think that, you know, that was a pivot point. Certainly, though, as we pretty rapidly moved to the place where we better understood the virus, I think at that point, you know, we were able to move back into a less self-preservation mode amongst healthcare workers.
And I would agree. I think for us earlier on, we saw the same thing, but as time progressed, it was more of preserving the home of the employees versus themselves, which is what Lee described as well.
Do we have any other questions?
There's a hand over there.
All right. See through the podium. Okay.
Hi, Paula Fite from Advent Health Ocala. I just had a question for Dr. Taylor about the rooms. My experience to bring down infections in the OR, 87%, it's multifactorial. It's not just one item. So to take the Hawthorne piece out, what was the percentage prior to actually working on it? Like how many of the infections came out of those rooms compared to the other rooms? Maybe you brought that up and I just missed it.
So the infection rate, I thought it was pretty good in those rooms. It was 3.9% before the environmental monitoring and management, according to a health score, was implemented. And it went down from 3.9% of SSIs. And I can't tell you all the organisms that were responsible for those, down to 0.5%. So that was, starting at 3.9, that was an 80% reduction.
Thank you so much.
Is there another question? Last call. All right, right up front.
How many hospitals, if the Indiana hospital didn't listen to you because of the engineers, are other hospitals listening? I hope the answer is yes.
Well, it's interesting. So in my work now about managing the air from a health index, to really truly align the ROI with this implementation, we've had the best traction in senior living communities. For a number of reasons, like elderly are vulnerable to airborne exposure. An empty bed in a senior living community has to be, if say you're a resident and you go off to the hospital because you have a viral infection or you need evaluation or treatment, that bed has to be held for you, so the senior living community loses money. So hospitals have been hospitals are focusing on contact transmission, which is important, but it's not the only thing that's important. So very few hospitals, unfortunately, have implemented air monitoring from a human perspective in patient rooms. But senior living communities have, and in Vermont, there was a community that was monitoring and managing according to health, and they had about 8% of the COVID deaths that nearby senior living communities had. It's phenomenally powerful.
I just have to say, I heard you present on this years ago, probably at a Leapfrog group meeting, and the fact that there's been not that much uptake is really troubling to me.
Yeah, well, so I talk a lot about humidity, but what humidity influences other pollutants. And so when, in getting ready for this meeting, I was looking into the Leapfrog data around certain areas, certain hospitals are struggling with certain adverse patient events. So I actually am beginning to do a report on different air metrics, such as ozone, with a time delay, impact the transmission of certain infectious organisms. So I think that humidity is very important, but these other pollutants we can't do a whole lot in the outdoor environment, like immediately, but we can certainly be aware of them and manage our indoor environments. I'm not sure if that answers your question, but.
All right, well, please join me in thanking our wonderful panelists for a really great discussion. Thank you.
That was great. Very educational.
Good job.